Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongom egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
So today, we've got a great lineup, and without further ado, I will introduce today's speakers. So our first speaker is Dr. Kheira Jolin-Dahel, and she is a family physician, as we all know, here in our department, and she's one of our preceptors for the Winchester training site, and her practice includes primary care clinic, interpartum obstetrics, and emergency room coverage. And she's also our director of quality improvement for the department. And her research interests include rural primary care and obstetrical care, as well as innovation in medical education. I think that's what we're going to be hearing about today. And she's also, and most importantly, a mother of 4 children. And she was able to get here today for 8 o'clock. So good to see you, Kheira, and we look forward to your presentation. So I'll just hand things over to you.
So thank you very much. So yes, this morning I'm talking about Escape the Office, the use of a virtual reality escape room as an alternative strategy to teach quality improvement principle in medical education. And so this is a room that was designed a couple years ago and we implemented in academic day in 2023 and 2024. So we're going to go over a little bit of the results from implementation. So my objective today is just very briefly go over gamification as an educational method in family medicine, have a very brief overview of the room and its design, and then go over the feedback from the residents from the 2 years that we rolled it out. So gamification is using game strategies in non-game setting. And I think we all do it to a certain extent. You do a PowerPoint and a didactic session, and then you do a little competition asking questions to the learners. So it creates more engagement and it's just a more positive learning environment. So this is the strategy that we use it. We just bring it up to the next level. In this specific setting, we designed a virtual reality escape room to test quality improvement knowledge. And so in addition to that, the learners have to work in teams and communication and use a little bit of leadership to escape the room. And so the room itself is not a standalone. So the residents do have a didactic session to learn quality improvement principle before, and then they use the escape room to test their knowledge. So the room itself was designed co-designed with medical students to which we gave the QI teaching. And then we identified the principles that we wanted to teach or reinforce. And then we brainstormed all sorts of puzzles, escape room, tabletop game, computer game. And then we matched the concept to a game that we thought would be useful to reinforce the teaching point. Then in addition to that, we created some teamwork and interaction, communication woven into the puzzles to make it more like a real escape room. And then the game also has been translated in French. So the escape room objectives are to review QI terminology, identify a gap in care, review the SMART aim component, review some root cause analysis, specifically the process map, the Pareto chart, and the fishbone diagram, prioritizing change idea based on your Pareto chart, and then very basic understanding of run charts. So this is an overview of the escape room. So if you're familiar with escape room, this is gonna look fairly simple. But if not, so when you go in like a physical escape room, you might have only one room or you might have multiple rooms. So our room has 3 rooms to escape win the game. And then each room has several puzzles. The puzzle might be serial, which means that you have to solve one puzzle before you move on to the next puzzles, or they might be in parallel. So you could solve either a puzzle, like for example, 1.2 or 1.3. It doesn't matter what order they're solved in, but then you must solve both of these before you move on to puzzle 1.4. And so this is similar to real escape room. So if you have a multiple people on your team, you might split between the different puzzles and you can solve the room more efficiently. Or if you're struggling, then the whole team can work on one puzzle and then work on the other puzzle. But ultimately, like some of the orders doesn't necessarily matter. And then the puzzles that are highlighted in purples are the one that require teamwork. And so I'm specifically not going into details in the puzzle because it's like the mystery of the escape room. You're not supposed to know what happens in there, but I'm certainly happy to answer specific questions as needed. But so the puzzle that are in purple require some teamwork. So the like 1.4 and 3.2 could be solved by one person, but it's less efficient. So it's faster if you work together. Puzzle 2.3 specifically requires 2 people in the game to maneuver it. Otherwise, you just cannot solve it. So it does require teamwork. And then on the third room, it's that Puzzle 3.2 requires information that you gathered from Puzzle 3.1 in order to solve Puzzle 3.2. And they're in the virtual environment, they are in separate rooms. So if you're doing it by yourself, you have to run back and forth between the rooms. But if you're doing it as a team, your teammate is in reality sitting beside you. So you could be in separate rooms of the virtual environment, but just chatting to each other, sharing the information to solve it more quickly. So the premises of the escape room is escape the office. You had a long day in the clinic, you're running late, you have to be home in an hour, but you realize that you're locked in the office and that you can't escape. So then you know that the previous owner, Dr. Quality, spread some clues in the office to be able to escape. And so you have to gather the clues and escape on time. So like I mentioned, we introduced this in the academic days 2023-2024 in November. This is what it looks like. It's run out of the Peter Moran location and the residents come. They're paired in groups of 4. They're set up with the virtual reality equipment and controllers. And then there are facilitators giving support for technical issues and hints that are specific to the game if they get stuck. And then, so at the end, we asked them a little quick exit survey of 5 questions. So the first question was, did you enjoy the experience? And so most residents had a fairly pleasant experience, with the majority rating it at 4 or 5 out of 5. And then there's always a couple people that really did not have a great time. Like the one person in 2024 was like, no, this is horrible. I don't want to do this again. We asked them if they like virtual reality as a method of learning. And so again, the majority of people thought it was a useful and pleasant experience. We asked them if they thought the level of difficulty was appropriate. And so most people thought it was appropriate. A couple people thought it was a bit on the harder side. And then there's a very few people that thought it was a little easy. Nobody thought it was way too hard. So I think that's good. We do want them to escape in the end. So that's good. And then we thought, we asked them if it was useful to consolidate their QI knowledge. And so that was an overwhelmingly positive response here. So even though not everyone had a pleasant experience, they did think it was useful to practice and test their QI in specific problem-solving puzzle type things. And then we ask an open-ended question like, would you change anything? And these are just the big team that came out. So the most common limiting factor for the experience is nausea. So the virtual reality can be quite nausea-inducing. And so if people are very, very sensitive to that, it is not very pleasant. Some people might had a little bit of nausea, but still thought it was a pleasant experience. Then there were a couple comments about time. Some ask for more time, some ask for less time. There's quite a fair amount of people that ask for no change at all in 2024. In 2023, there was a less popular answer. And then a couple comments about hint and technical issues, which we tried to solve every year. And then there were some random other comments about like very unspecific, like change the last puzzle, but that doesn't really tell us anything, or have a computer version. So it was just other comments like that. And then we ask them their favorite puzzle and their least favorite puzzles. And so there's quite a spread of puzzles that are alike amongst the residents. The monkey puzzle is probably the most difficult puzzle in the escape room. And you can see, I'll just go on the next slide, it's which one is your least favorite puzzle. So it's a little bit of a love-hate relationship on the monkey puzzle that's like really like people love it or they hate it. And then the other one that is the not really like is the Pareto chart, but it is also one of a little bit more difficult one. But as you can see, there's like quite a spread of people that like them, and there's like quite a spread of the ones that they don't like. Well, it doesn't say doesn't like, it's like least favorite. And that's it. So in conclusion, residents seem to have enjoyed our experience. They enjoyed using virtual reality as a method of learning. They thought the escape room was useful to consolidate their knowledge, and the level of difficulty was appropriate. The biggest limiting factor for the experience was the virtual reality inducing nausea. And so one of the change that we did from 2023 to 2024 was, so in 2023, if people were nauseated, they could go in a casting room. So they would leave their team and go in a separate room with another team and just watch the game from a screen, which wasn't great because first of all, we had a lot more resident like tap out of the VR than we expected. So the casting room ended up being quite full. And then they were not necessarily in the same spot in the game from where their team were. So it's creating a little bit of disengagement there. And so in 2024, one of the things we changed was having a PowerPoint versions of the puzzle. So if they had to exit the virtual reality environment because of whatever reason, most often nausea, but whatever reason, then they could stay in their room and they would have only the puzzles as a PowerPoint version. So it wasn't very interactive, but they could still see the information that their residents, their teammates were getting, so to help them solve the puzzles of the escape room. And another thing we changed in 2024 was that some of the facilitators were PGY2 and the second facilitator was the DFM employee, as opposed to 2023, both facilitators were DFM employees. So I think that having the PGY2 there was a little bit more helpful in giving clues that were easier to understand because they had done the escape room the year before. So they kind of knew a little bit what to do. And then it also, again, consolidates the QI knowledge for the PGY2. So it's like one added layer of teaching there. So I think that worked well. I haven't had a chance to touch base on the details of that just because it was very recent in November, but I haven't heard anything absolutely wrong about using the PGY2. So I think that's good. And that's all I have.
Kheira, thank you very much. Well done. You know, if I can start the question, we've got time for discussion here, and I'm going to start things off actually, if you don't mind. First of all, this is a great innovation. And it's not just an innovation, you've actually implemented the innovation. And therefore, you got to tell this story. This has to be written up. And a couple of things in order for you to do that. The first one is you got to engage in the education conversation. Okay, so that means you need to bring some theory into this. So it's gamification, it's interaction with other people, it's interacting with technology. So I'm going to suggest, and you don't have to do this, there's lots of theory that you can bring in here, but I'm going to suggest social materialism. Okay. And this is an area of social constructivist theory, but you need to explain the innovation in terms of this theory, all right, moving forward. That's the education piece, right? The second one, and you've done a great job of it, is describing the activity itself, like the innovation you've described well. Now, the other thing that you have going is you've made it sustainable, right? You had the first year, you made improvements, you moved it into the second year, right? You're building on it. And that's a story that people want to hear. That kind of makes it more generalizable too, right? And then I guess the third thing, and a really important thing for evaluation of innovations, is that you frame it with an evaluation framework. Most common one in medical education that we tend to use is the Kirkpatrick hierarchy, right? And you've already captured a lot of this data in terms of reaction, in terms of building knowledge, all right? But now the harder step to move over, that next level, is change in behavior. So you may not be able to report this, certainly in the first bit, but if there's any way, think of it for the future of capturing that change in behavior. Our residents, once they're in practice, are they engaging in QI? Do they make some reference to this QI activity that they participated in their training? That kind of thing. That would be really powerful. So anyways, kudos. Well done. This is terrific stuff. So I'm going to open it up now for questions.
Hi, Doug. It's Claire Liddy. Hi, Kheira. I'm just going to jump in. I'm en route.
Yep. Very good.
Yeah, really nice. I agree with Doug's comments. Like, let's take it to the, get it published. There's a couple of papers already in there because you want to share. And I guess what I'm curious about is we would love to, and the department would love to support further activity along this concept. So what else are you thinking about or already doing, Kheira?
Do you mean specifically with the escape room or just like in general?
Yeah, well, gamification or like what are some of the other competencies that could be, do you think could be done also through an escape room, given we've got that sort of, I guess, foundation built? So I'm just interested in what else you're thinking about.
So that's a big question, Claire. In terms of I think so there's a lot of okay, so I think in terms of escape room, there's a lot of anything that you have to kind of like problem solve or get an answer or anything like that we could turn a concept into an escape room. I think one of the idea that had been kind of brewing in the back of my mind was one for like obstetrics. It didn't really match with the virtual reality environment because I was hoping to get some tactile, like you examine a cervix and then the dilation that you get gives you like a combination for something. So the virtual reality technology wasn't quite there yet. But in a physical escape room, there might be something there. Yeah, I don't know. I'd have to think about it, but I'm sure that if I sit for 5 minutes, I'll come up with a list of cool new ideas I would be excited about.
All right, thank you. You had talked at one point, I think, about doing like a simulation sort of a hospital city.
Oh yes. So what we had was kind of SimCity Ottawa, which the point was to get residents to manage their schedules in terms of once you're an attending, there's so many options that are offered to you. And then often it's very easy to sign up for more and then realize like, oh my God, like I actually have, this is too much. This doesn't work. I didn't think it was going to turn out like this. So it was offering them like a simulation, longitudinal environment where they could pick how much they work, how many patients they have, whether they cover like emergency and obstetrics and locums and teaching all these things. And then together with that, like identifying what was important to them. So was it like lifestyle balance or family, or was it like, no, I want to be the best doctor out there. I want to be like the top researcher, the top educator. So identifying their values and then seeing if their choice matched their values and how it affected their life work balance overall. And then we wanted to add other layers, like you can have family, you can have partner, you could be caring for your aging patients, and you have to have at least this amount of sleep per hour. Like you can tolerate a little bit more work, but if you do too much for too long, then you lose point because you're burnt out. So there was like a lot of layers of complexity that we were playing with. So we do have like a very basic version of this, which was getting picked up by capstone projects, so engineering students, and it didn't get picked up the last semester. So it's kind of been just put on hold for now until, yeah, this is something that is in the work, and so it might be coming up in the next couple years.
Great. Okay. Thank you. And for all those who are listening, you can see we have a gem of a resource here in terms of doing some of the gamification work. So thanks, Kheira.
Thank you.
Kheira, there's a couple of questions in the chat. I'll just bring them up. Owen's asked, well, how do preceptors perform in this activity? And maybe others who are not used to escape room culture?
Yes, so we did test it with a couple of preceptors. So let me think. I know Shauna for sure did it, and then other like non-QI leads, like a couple of preceptors from Winchester tried it, and so they did okay. So at that time we were more like testing like how many people can do it at the same time on the server, and like tech issues and things like that. But like Shauna, because she had some QI knowledge, was able to work through the puzzles with no issues. We haven't tested it with preceptor only team. It was always a mix of preceptors and residents in the like early testing phase. So I don't know the answer to that, but I'm certainly happy to see if we can set it up with preceptor, and we can time you and say like to your resident, this is how quickly they escape. Can you beat them? And what was the second part? Sorry.
Oh, that's it. Just
we're culture.
Not used to the culture of escape room.
Yes. Yeah. So there is a little bit of an approach to escape room. And if you've never done an escape room before, then that certainly adds a layer of difficulty in this setting. But that's what we had the facilitator. They have a list of preset hints. And like, this is like the easy hint. This is the next level hint. This is almost giving you the answer hint. And then there's the answer. And having the PGY2 there as facilitator this year, I think really help that if you're not used to the escape room, it like really helped the student navigate this environment. So just for fun, the escape rate the first year was 35% and the second year was 73%. So
change. And Zach's asked a question here around pre-post knowledge assessments, in order to quantify change, in the knowledge domain from the escape room. Have you considered that?
We haven't done any of that yet, but yes, it's certainly something that I was thinking about, of like you mentioned, like long-term effect of like retention. So we'd have to do something like that, which we haven't done yet.
Exactly. Something a little more longitudinal so you can see change in behavior too. And then, when do you give that, right? Because everybody's getting a lecture, or, there's some didactic component, as you mentioned beforehand, right? So you have to sort of figure out how and when to do that. So that's great. Good. Any other? Oh, Bill, go ahead.
Hi, Kheira. This is really fascinating. I'm guessing that someday in the future, you expect most learners to own these headsets and do this from their homes, perhaps. So can you tell me how many people own these now and what's happening to the uptake of people embracing this kind of technology?
So this is a guess. I'm not sure. Like I haven't looked into that specifically. I'm gonna guess that not that many learners have the headset at home. Uh, but I think some do. I know one of the Winchester resident was mentioning there's this place you can go and they have all sorts of virtual reality game and it's like an arcade but virtual reality. And so I was like, oh, I should try it and see what else we can use for our department. But I don't think it's super common right now. I do think it is getting more popular and it's a new sort of gaming console, so people will be getting them. I also know that when I presented the escape room to FMF last year, they were some remote location asking, oh, we could do that even if not everyone is in the same spot. If we provided them with headset, they could do that learning even remotely. So that was something that was discussed last year as well.
And with that, we'll sort of transition to our second speaker, and that's Dr. Allison Eyre. And Allison, as we know, I mean, she's a former postgrad director of her department, family physician at the Centertown Community Health Care Center here in Ottawa. She has a lot to tell us about. She is an associate professor with the department. And Allison, if you're there, I'm going to hand things over to you.
Okay, guys. So this is research that was done at Centertown, graciously with the support of a prime grant, which Andrew McClellan, who's one of our nurse practitioners, applied for. And it was done so much with the help of a then medical student, now, as many of our excellent medical students, a resident in Toronto in emergency medicine. And she and I presented this at AFTO, actually on the same day that there was the family medicine get together day. It was the 25th of October, but so I did not join you guys. I went to Toronto, and I presented this at the Association of the Family Health Teams of Ontario, which is AFTO. And so this is medicine like an umbrella protecting me from the rain until I get to my destination. It's looking at the implementation of work we have done at Centertown with marginalized populations. I will say these are all of the various authors, which we could never have done this without. So much thanks. Manisha kept us on track all the time. Carol Geller is here with me, and as Carol is so good at doing, she'll pop in and say things at various times. And I will say that neither of us are going to be your sharpest. If you've got really specific questions about how the research was done, we will completely fade and pretend we're not here, because I'd say that was mostly Soha, so we'll answer what we can, Soha and Manisha. Real thanks to Centertown, the Department of Family Medicine, and then all the participating partner organizations, because we really had to look at who was around us. So the learning objectives are to be able to describe a program that serves marginalized and medically and socially complex individuals, to gain knowledge as to how to evaluate the implementation of complex healthcare programs, and to describe the development and implementation of holistic interprofessional programs to address the unmet needs of our population. And I will say thanks so much to Andrew. So much of this work happens in the community, but we never document it. Okay, because we've all got our, we're all focusing down. And so it's very hard to hear about programs like this. And so the whole team was really good at being able to do this. So background, you guys all know this. Primary care is the entry point to the health system for most health problems. High quality primary care systems can contribute to the reduction in avoidable hospitalization, better health outcomes, and a decrease in the mortality rate related to socioeconomic disparities and higher life expectancy. Quality care can be measured and improved over time through the delivery of evidence-based care that acknowledges and addresses server, user, patient, client experiences. So the population that we work with is this study was done on is an urban marginalized population, and that is defined by those who experience barriers to engaging in mainstream social, economic, cultural, or political life. That includes people experiencing homelessness, people who use drugs, people who are involved in the correctional system, Indigenous people, people with mental illness, some racialized minorities. Now, I would say some Indigenous people, not all, and certainly not all racial minorities, but they are overrepresented, and some members of the LGBTQIA plus community. Okay, so we were looking at complexity, and so it's really challenging to kind of define what complexity is, but we were looking at severity of their psychological and medical conditions, lack of social safety or participation, lack of coordination of care, or negative care system relationships, which you guys know can be really crucial. Linked to the social determinants of health, social and environmental elements contribute to an individual or community health risk. As you know, that sort of all of those social determinants relate to how people can access care and how they do access care. So identifying, it can be really hard to exactly identify this, and that's what we're going to go into. So barriers to primary care, guys, none of this is new to you. Economic, geographic, cultural, and language barriers may limit access to care. Many clinics require proof of health insurance for billing, and that hinders, if you think of that group up there, you may not actually always think about it, but a lot of those people do not have a health insurance billing number. There may be one for them somewhere, but they don't know what it is. And this really hinders access. Lack of an address, lack of ID, access to transportation, telephone. I don't know if you've ever tried to get someone an appointment at the Ottawa Hospital without a telephone, but you may as well just forget it. Social supports create barriers to access to inappropriate care. And equitable access to primary care requires health providers and organizations to consider the social and health determinants. So the purpose of this study was to evaluate the implementation of a program developed to meet the needs of urbanized margin populations in one service area, Ottawa, Canada. We only looked at our population. So what is the quality of the implementation of the program in terms of its service and clients' perceptions? And does the implemented program align with its intended aim of engaging and caring for marginalized and complex populations? The setting of the context is our, what you can't see is that as soon as there's any warmth out there, that window that's a little bit on the right is completely an encampment of people getting high recently. I have never learned more about the pipes people use than if you just kind of watch what's going on there. We are, as many of you, right in the middle of this crisis. Okay, so Centertown, we include the city's largest shelters. A young man's shelter is right across the street from us. A woman's shelter is right up the way, and a lot of rooming houses. The mission of Centertown is to lead the way in improving health and well-being for people and communities. The vision is health equity for all members of the communities, working as a collective to address the systemic barriers and challenges to accessing health services. The values are equity, empowerment, excellence, and respect. And we aim to enhance access for all of the people with complex needs. So the Urban Health Program, I can't see Carol because I can't see anyone. If you want to jump in here, Carol, don't hesitate. But it was created to provide, Carol has been a real strong voice in creating this program. So it was created to provide high quality, comprehensive and interprofessional primary care services tailored to target the needs of marginalized individuals in the community. Emerged organically through relationships between case managers, primary care workers in the same space, often serving the same clients. Objectives of the program was to reduce the barriers to healthcare in the system's most marginalized population. And I will say that a lot of this just came out of people saying, we cannot serve people this way. We need to come up with a better way. This program, the teams are always talking as the environment changes around us. So the Urban Health Program, it's flexible. There are no appointments in these programs. Primary care clinics, there are appointment-based, if people can do appointments, there are availability for appointments-based, and their families when that serves them the best, but they're not stuck in that structure. Social support services encompassing harm reduction, case management, coordination, social healthcare system navigation, showers, shower access, coaching and counseling. And I can't say more. This program could not run without those social services. That is a really key pillar to this. On-site access to psychiatric services, another key. And if the patient can't see them, the team has access to a community-based psychiatrist who's worked with this team over many years. Outreach nursing services offered in on the work on the street. They work in the rooming houses, the shelters, the women and families and youth shelters. And that's also very crucial that we can go out and do follow-up. Okay, so the inclusion criteria, this program has very specific inclusion criteria because it's very much focused on the unattached. So they have to have no primary care provider. They have to have one or more of the following. Like, they don't have to have everything. Obviously, that's not going to work. Homeless or vulnerably housed. So they may have a provider in Orleans, but they're now unsafely housed in Ottawa. You know, that would fit in. New immigrant or refugee, at-risk youth, individuals suffering from mental health or substance use issues, involved in the sex trade, and no valid health insurance. Okay, so the program evaluation was done. It was done using the framework that is described in Proctor et al. It is an implementation framework, and it examines implementation, service, and client outcomes. So you can see there, I'm just going to give you an example, that for client outcomes, satisfaction, function, and symptomatology were the relevant ones. And similarly, under implementation and service, outcomes, looking at what are the goal points that we can look at in each of these. So we just sort of went through that. So outcome measures for implementation: appropriateness, acceptability, penetration, and fidelity. For service, it was patient-centeredness, effectiveness, and equity. And for client satisfaction. So this just kind of goes through that again. It shows you, it pulls that out more. We really were very careful. This is the royal we, I'm going to say, as I say, Soha and Manisha did so much of this, at really, you know, fitting everything into these different spaces. So the evaluation methods, the client records, there were 570, and we looked at complexity, and we'll describe that in a minute, how we looked at the complexity scores. Then there were 41 semi-structured interviews, and there were 30 client satisfaction reports. The evaluation, so the client records, they were the community health center records, and that was done in a quantitative, using a tool called AMPS, which is a Health Connection Clinical Complexity Assessment. It's derived from the Minnesota Complexity Assessment Method, and that was quantitative. Semi-structured interviews were qualitative, and the client satisfaction was a questionnaire, and that was quantitative. I am not going to stay on here very long because do you guys feel like that since COVID, we're allowed to have slides like this? Like, I would never, ever, ever, ever have allowed a slide like this. So I'm going to get rid of it. Because this is more of a pre-COVID slide. So what were the results? We may end up with some post-COVID slides. Again, we'll try. Okay, so client record extraction, July 1st, 2020 to June 30th, 2021. You might notice something significant happened in our lives during this time. This was done during COVID, which obviously has an impact on various things, but we did not shut these clinics down. It was very evident to us when we tried to shut down, even for a week or two. Carol can say how long. I don't think this clinic was shut for more than a week or two.
We never shut. We got busier.
Yeah.
We never shut.
We were super aware that whatever people said about shutting, our clients could not shut. We also, I will say, from a department, we never blocked our learners. We actually, as long as they were willing, if we were open, they were seeing patients. Total number, we looked at how many unique visits happened during this time visit, total number of face-to-face visits, frequency of visits, types of insurance, housing status, financial situation, and chronic disease. So there were 570 unique clients seen. The total number of visits at the clinic was 1,859. So this is who had health insurance, IFH, and no coverage whatsoever. Housing, you can see the majority were homeless, but there were quite a few who were in rooming houses, and then people who just, nothing was coded for them. This is the income. As you can see, the majority of these people have a very low income, and then, you know, some may have a little bit more going up. Okay, so the chronic illnesses, no surprise, the biggest ones are psychiatric disorders and substance abuse. However, diabetes was well represented, hypertension, hepatitis B and C, HIV, and TB. You also have to realize, sort of looking at chronic illnesses, is that we have various different populations here, but particularly for the urban, kind of your traditional urban population, they don't have a long lifespan. So you're not going to get the same flow of chronic illnesses because they die before that all occurs. Some of it occurs and some of it kills them, but it kills them a lot earlier than it kills the rest of our population. Forgive me for being blunt. Okay, concurrent issues, problems with refugee claims, 26%, language barriers, big immigration issues, and problem with the healthcare system. So the complexity assessment, this tool looks at attachment, it looks at medical, and it looks at psychiatric, mental health, and addictions, and it looks at social. We reviewed charts on 2021 from November 1st to November 30th. The total complexity for clients was 16.68 out of 33, which actually puts it quite high. We can discuss that in
Alton,
Yeah.
I just want to give context for that because that number meant nothing to me when we got that score. But when we went back to the paper, it correlates with the score of those in the lower downtown east side of Vancouver, just to give maybe context for others.
Okay, it'll have context in 2 secs too as well, but it didn't have that great context, which actually sort of sets you where you are. Medical clients had a higher total scores than female, and the highest scores were in the 40 to 49 age group. So exactly as Carol just mentioned, what this means is that so the attachment scores reflected what we thought is that we were principally targeting people with no primary care provider. The complexity scores meant that people had complex symptoms, but actually they were relatively well controlled. The psychiatric score, people had mild to moderate mental health addictions, and the social complexity meant they had moderate to high degree of poverty in populations, low access to social supports, and a hesitant attitude toward providers, which is important to acknowledge. That is a post-COVID slide. Semi-structured interviews. Client interviews were 31, key informant interviews were 10, and that was programs and staff from partnering agencies. Key themes, building relationships, the importance of wraparound care, medical, psychosocial, and advocacy, access to low barrier care, and room for improvement. There's always room for improvement. So these are just some of the quotes. I'm not going to read all of them, but client reflections. I like the atmosphere, the way people treat me. People are empathic, kind, helpful, and non-judgmental. Non-judgmental is key. Centertown is safe. No judgment zone feels like home. Centertown feels like an umbrella protecting me from the rain until I get to my destination. Obviously, we use that quote for our title. And then for staff, it was about building relationships and getting to know people. And then once again, the non-judgmental. Wraparound care for the clients, the ability to get everything that you need in one place. Reminder calls for those who have telephone, being treated, well organized, really important for staff. The health center offers a little bit of something for everybody. It's down to, as staff, how valuable it is to know you have other staff members who can maybe deal with the substance abuse, harm reduction, something for everyone. And there's good feedback around the community. Access to low barrier care. Other places won't accept refugee patients. In many places, refugees have to pay up front and they don't have the money. The staff reflections were for people with difficulty accessing traditional care. We help them bridge into healthcare and connect them to the community health centers. Remember, these staffs were not necessarily our staff, but staff at our partnering agencies. Room for improvement. The program is hard to access because only a certain number of clients can be seen, and if I don't get in time, I will not be seen. And that is very true. Obviously, like any service, we can only see who we can see, and the times stop. Staff reflections, a feeling that we could offer more in addictions medicine, a safe injection site. We're never going to see those again. So a lot of the issues, and I don't know the kind of clinics everyone's here. I can't actually see who you are, but for anyone who's dealing with addictions, this is a really tough time because the government is changing its philosophy on how to deal with addictions. That wasn't true there, though. Okay, so a client satisfaction tool. The total was 18.5, which doesn't really mean as much, but it's out of 20, so that's pretty good. People were satisfied with the quality of the service, the types of service. They were generally satisfied. So the summary of the results. So that is also a post-COVID slide. So we're going to go into something better. Conclusions. Clients and key informants found the program to demonstrate the fidelity, appropriateness, person-centered equity, acceptability, and effectiveness, all the things we were looking for. So this has been a successful implementation of this program based on this evaluation. Key areas for improvement were identified. Increased diversity of the staff to better represent the population served, expanding the program hours and availability to allow for better access, and improve access to harm reduction services. So limitations of the studies, definitely interviews were conducted at one point in time, and that point in time was COVID. May not have captured evolving perspectives of participants. Possible than individuals who are more enthusiastic about sharing experiences and were more likely to participate. So as you guys all know, in research, you get the people who want to be researched. So the ANTS tool has been criticized due to the subjectivity of the questionnaire method, aimed to mitigate the limitations of the study questionnaire subjectively by holding provider training sessions on the use of the tool prior to its use. We did do that. Since Carol and I are the ones who used it, we were the ones who got trained, but we definitely did the training and validation, but it's still not the best tool in the world. Medical mistrust and potential impacts of sharing information, especially marginalized population, have a strong negative influence on health systems interaction. And this is a real key for anyone who tries to do research in vulnerable populations. Obviously, they're not a big fan, not obviously, often they're not a big fan of being researched. They feel vulnerable and they feel very vulnerable about answering questions. Okay, so I'm going to take this down if I can be smart enough to stop sharing. There you go, I did.
Allison. Carol, too. Thank you so much. That was a great overview of the project. Just to start questioning, you had a prime grant, so you had support, but you've also got a great frame here and terrific tools that you had at your disposal. Just wondering if any advice for other clinics that might be interested in doing a deep dive as well.
So I'll start because I'm probably Allison had prior research experience and was a godsend. Andrew has since got a PhD with the research. I am no further along. If anything, I'm worse, but not because of the prime grant. My advice would be start with just a quality assurance study. Start with just QI. And we would have stopped at QI if it wasn't for Doug, who then pushed us into the research component for publication and the purpose of the prime grant, and really see that you're doing what you say you're doing. I found that extremely helpful.
Doug, I'm going to really follow up with Carol. First of all, I think the thing is the idea. If you have a program and you think it's good, please move it forward, because it's really hard to find literature on how to do these things. But I would say the support from the department was amazing, like not just the prime grant, but the help with everything else. Like we had, and I don't know, Carol know where we got the medical student who was spectacular. We had a psychology student, like it's the team. But I also think, and we did this during COVID, and I can tell you the amount of times Andrew almost threw his hands up and said, we are leaving. Don't do that. Don't give up. Primary care research has to be done in primary care. The research of vulnerable populations will never hit your tertiary care studies. If we don't represent this population, no one will.
And we actually came to you guys, Doug. I don't know if your team remembers, but we were super stuck for our focus groups. And actually we came to you this meeting, and actually that's how we managed to push forward, was on the suggestions.
I want to say congratulations. It's not only an incredibly important clinical service that you're offering, it's amazing to me that you were able at the same time to evaluate it. So kudos. It must have been extremely difficult.
We don't have a lot of friends left, Bill.
I want to talk about one of your outcomes for clients as satisfaction.
Mm-hmm.
So, I mean, really, I think some leniency has to be given the difficulty you would have following these people, the inability to link to health administrative databases because they don't exist from that perspective. But notwithstanding that, I found myself wondering whether you would be better off not to mention client satisfaction. You address it in some other ways through your interviews and so on. And satisfaction as an outcome really is not well received. The main reason being that it's so relative to people's recent experience. So if you measure satisfaction in the poorest part of the poorest state in India, you will find higher levels of satisfaction than in the richest clients in New York City. So it's really is only measuring how people relate the care they just got to what they had the last time they got care. So it's not a great measure. People instead want to talk about patient-reported experiences or patient-reported outcomes, which I have no idea how you would measure that in this population. So, and what's done is done. But I would personally just leave it out. I wouldn't
Bill,
mention it.
It's a great point. I do think one of the things is that you had to pick a framework, and the framework we picked had that in it.
Right,
so you have to have, like, I do think as researchers, you can't just choose to get rid of things in your framework because that tends to destroy the validity and all the rest of it. And I agree with you, and I do think satisfaction is probably the weakest. I do think involving the patients in the research, I think that there's something about patients being asked to participate and being shown that we care to have their voice, and that is going to have weak things like satisfaction. We do not have a good way to get patients' responses, but I do think that patients knew what we were doing is actually useful and trying to figure out and hear from them. Even in this, you've never heard me talk about education research, but satisfaction is one of the things that I have the most problems with. Happy bums in a seat is not a very useful tool, but I still think we need to keep trying. So I appreciate your point a lot. I think we need to keep trying. Carol is dying to answer.
No, Bill, as I was listening to it, and I see in the chat a question about inner city. Inner city tried to track hospitalizations. Really one thing I really wanted to see is one ongoing care, commitment to their own care to a group of people, but we couldn't figure out how to track that. And we also wanted to track kind of decrease hospitalizations rate. And to be honest, selfishly, because we're always struggling with funding, and we felt that this might help justify more funding if we could show that. No one can figure out how to do that. Inner City kind of did in 2000 to justify their funding, but there's not great data out there because this is just, like you said, they don't have OHIP, they have IFH. It's just such a hard population to track.
Those are very compelling answers that I must say. Doug, what's the name of the woman who gave the plenary at NAPCRAG a year or two ago that does this kind of research in San Francisco? Do you remember it?
Oh, yeah, her
first name starts with an L, and her last name is like Gerlin, or it starts with a G. I forget. Yeah, but if you were to, it would be possible to find out. Yeah, because similar work that she spoke to at NAPCRAG at a plenary session.
I'll get the name to you. Yeah.
Yeah. Well, Andrew has his PhD now, so if we hand this on to him, I suspect this will keep going. And he's moving back from Tanzania, so kind of good timing.
So there was a question about did we coordinate with Jeff Turnbull's work? Jeff Turnbull does exceptional work, no questions asked. We actually really just wanted to look at the services that we do, not obviously, but we do work within all these realms. We work with all these people, but our interest was actually this was a program evaluation of our program.
Yeah, we're actually very different. I'm actually going to build on that because I've kind of been involved in this program in parallel with Inner City. We started at the same time. They actually serve downtown. They serve the downtown core. We actually deliberately try not to duplicate, and so we don't serve the downtown core.
Okay, any other questions? As I say, we cannot say more about the support we got from the department. Carol graciously said that I have research experience, and that may be true, but it doesn't mean that I know how to do research, even slightly. We were blessed by an amazing team supported by the department and Centertown and our partner agencies and our patients who are problematic but lovely.
It's Claire Liddy. Congratulations on the work. I love your plug for if you don't do the research on this, who else is going to do it? So that's why we have to keep going with it. Glad that the department supports helped out.
No, Claire, it's true. Because I truly believe if we don't do research where we are, no one is going to do our research. No one is going to represent our patients. And the question about are the physicians, okay, so let me just quickly in the next 2 seconds, which we don't have. Centertown is a community health center, which is globally funded. All of the staff are on salary, not just the physicians. It allows us to be able to work in that interdisciplinary team. And just a plug, if you watch where Jane Philpott is hoping to move us, there is a strong desire to move more into functional teams that can support this kind of work.
And Owen, we have a slush fund for those who have no health cards if we absolutely have to do it. But we actually try very hard to not use our slush fund. We try very hard. This is actually one of the philosophies of our program, is that you have access to what everyone else has access. So embedded in our team is a social worker who often can get people their lost ID back, get their health card back. It's not usually that they don't have it. It's usually that they lost it. So that's often our first step before we even order labs, referrals, diagnostic imaging.
Allison, Carol, thank you very much. Big thank you to Kheira too.
Thanks, everyone.